Hi, you guys. Thanks for joining me today. I am going to do everything possible so that this IG Live doesn't go anywhere. So I'm so glad you guys are here, and I'm just going to give people a couple of seconds to join me. And as you guys are gathering, I just want you to know that I also want to do my very, very best to be sure to catch every single question that you guys ask me as you're live chatting. So I'm going to be paying attention to those as much as I possibly can and answering them as we go. So welcome to another Ask the Egg Whisperer. For those of you guys who are joining me for the first time, my name is Dr. Aimee. I'm a fertility doctor here in the San Francisco Bay Area, and I love talking about fertility, and there's really nothing else I should be doing because I really don't know much about anything else either. And I love coming up with ways to teach people how to learn about their fertility, teach people how to ask the right questions from their fertility doctors so that you guys know exactly what's going on with you. One of the cool mnemonics that I just came up with, and I did talk about this on the last Ask the Egg Whisperer, but I want to be sure to share it with you guys if you guys haven't heard it before, is this. You guys have all heard of white diamonds, yellow diamonds. Let's talk about embryo diamonds. So a mnemonic is coming. So diamonds stands for everything that you need to know about your embryos. So many people do IVF and they have no idea what they're supposed to find out about their embryos so that they feel super informed about next steps. So I'm going to teach you that right now real quick, and then we're going to get to the question. So the D for diamonds is, what day is your embryo frozen or transfer? Is it day 2? Is it day 3? Is it day 5, 6, 7? And what does that mean? The I is implantation rate per embryo. You want to know that, you guys. Quality does matter. So finding out the quality of your embryo is related to that implantation rate. So something that you guys should ask. The A, are your embryos abnormal? I'm going to use the word abnormal because it's a little easier to remember than aneuploid. Aneuploid is the term that we use when we do genetic testing of embryos. M is mosaic. I want everyone to know what that is. Ask your doctor, what is your policy for mosaic embryos, for reporting and for transferring? You need to know that. The O is for, what is the O for? Official reports. If you don't see it, you can't believe it. So please get your official reports from your IVF cycle, including the embryology report and the genetic testing report if you've done genetic testing. Very important. The N is which embryos are normal. That's no big deal. We use the word euploid, but I'm using the word normal because it's a mnemonic and I need everything to fit together. The D, the last D is, will these embryos help you reach your dreams and goals? Okay, that's what D is. D is for dreams. And then I threw in an S, diamonds. S is sperm. You guys, you need to have a healthy egg and a healthy sperm. And I think people forget how important sperm is when it comes to embryo quality and implantation. So we need to pay more and more attention to sperm as we're getting older, as we're having babies. Look at the DNA fragmentation. I don't know if you guys knew this, but almost 40% of guys who have a normal semen analysis can have an elevated DFI. So talk to your doctor about whether they think that it's important for you to get that checked or not. So that's my embryo diamonds. I don't have diamonds, I have crystals, and I ordered some really big diamonds and they're coming soon. So I'm gonna wear them next week. They're crystals, and then talk about the embryo diamonds again. So let me see what questions you guys have, if anyone's asked any questions before I get started. Here we go. Is a 5AB a good quality embryo? And the answer is yes, it is. I wish there was a PowerPoint for this. Well, thank you. I should see if Instagram can integrate with PowerPoint. Next question is, do TPO antibodies cause miscarriages? So the answer is, it's controversial. I think it's really important to make sure that your TPO antibodies are not rising before you transfer. Make sure your TSH, free T3, free T4 are normal and stable before your transfer. If you're noticing that your antibodies are going up, up, and up, maybe that's a good time to just hold off and then talk to someone about, there are some novel therapies that you could consider doing to potentially bring down antithyroid antibodies. Next question is, I'm 43 with an AMH of 0.7. What can I do to even my follicles out? My doctor is suggesting estrogen patch or birth control every other day for 5 days before starting stim. Can you chat about that? And the answer is, I can chat about that. And I think that there are different strategies that you can use. That is one of them. Another thing that you can also do is maybe take half a dose of an antagonist like ganirelix or cetrotide. But taking a few pills, 1 pill per day of estrogen 3 days before you start stimulation. These are all things that you could potentially do to help balance out the eggs if your doctor is noticing that one is jumping out at the very beginning at the starting line. Another thing that you can do is consider a hybrid protocol. Rather than starting straight injections, maybe start with fertility pills first for a couple days and then bring in injections. Sometimes that helps as well. So another question is here, is embryo glue a norm for labs to use? Embryo glue is a great term for something that isn't actually what it says it is. Of course, the company wants everyone to believe that there is such a thing as embryo glue, but the answer is, I wish. Next question is this. Dr. A, thanks for another great show. You're welcome. Age 43, 5 rounds of IVF. No blast, thinking of a Menopur-only cycle for egg quality. Yes, I've been doing almost all Menopur cycles, and sometimes I add Gonal F, and I think that Menopur heavy cycles give us better quality embryos from my experience. Here's another question. Is 10 embryos good from 32 eggs retrieved? Yes, it is. It takes sometimes 32 eggs to get 10 embryos, and that's pretty darn good if you ask me. Anytime you get double-digit embryos is awesome. Okay, I'm taking baby aspirin in preparation for my FET. Should I continue that regime or regimen even after a positive pregnancy test? And my answer for that is yes, unless there's contraindications for you when it comes to taking aspirin, like if you have reflux, heartburn, if you have spotting or subchorionic hematoma. But aspirin in general has been shown to do a lot of things for us in pregnancy. Potentially decrease recurrent preeclampsia or even preeclampsia, potentially decreased risk of preterm labor. So now is a great time for you to continue your aspirin in pregnancy, but talk to your doctor first. The stuff that I talk about here isn't in place of your doctor's recommendations. I just share with you what I read online, not online, that sounds silly, in PubMed, in the journals that I get, and I'm always staying up to date. And the latest literature does suggest that, especially for women who are over 40, BMI of over 30, and a twin gestation or greater, would highly benefit from aspirin daily through the 3rd trimester, and some people have their patients continue through 34 to 36 weeks, so talk to your doctor about that. Next question, after a fibroid removal, any recommendations to prepare for stimulation? Yes, make sure your fibroid doesn't come back before you transfer. I know that's not a question about stimulation, but as far as fibroids, great job getting it out, and now start making your embryos, and then talk to your doctor about preparing for transfer very carefully before you actually do a transfer to make sure there isn't any scar tissue there. Should you test when you don't have any symptoms after 5-day transfer except period pains? Oh man, that 2-week wait, which in my clinic is really an 8-day wait, is torture. It's seriously like a form of torture to wait 8 days. I wish there was like a super early pregnancy test that we could do that tells us right away if someone is pregnant or not and if that embryo has implanted. Until that day, we have to wait. And 8 days is my wait in my clinic. And the 2-week wait can drive a perfectly sane person insane. So it's super important to be connected with people around you through online groups, therapists, talk to your partner, loved ones, have an outlet, listen to music, take nice walks. And at the end of the day, it is normal to feel like nothing. I mean, I have patients that come in and I draw their blood for their pregnancy test and they're like, I'm not pregnant. And then I show them the pregnancy test results and I'm like, you are. And then they're so surprised because they feel nothing and I have to convince them that they're really pregnant. Here's another question. What will work better for IVF? Fresh versus frozen embryos? And the answer is fresh is as good as frozen and frozen is as good as fresh. Except if your doctor thinks that fresh is better than frozen for you. So using a frozen embryo, some people say maybe the baby might be a little heavier, the placenta a little bit healthier and heavier. But when it comes to that decision, fresh versus frozen, it's not necessarily a cut and dry thing. That decision is definitely one you can make with your doctor and ask them to do a pro and con list for you. Here's a question. I normally take my progesterone suppository and PIO, that's progesterone and oil for those of you who don't know that, at 8:30, but my transfer's at 9. Should I still take it at the same time or earlier? I would tell you if you were my patient to take it at the same time and then bring an extra suppository with you. And after the transfer, replace it. Next question, any tips for preparing for transfer? Absolutely. Preparing for transfer, make sure you're sleeping well, drinking lots of water, eating healthy, and have reduced stress. Make sure you've done your cavity evaluation preconception labs. For example, are you immune to German measles? Preconception, pre-transfer, that's when you want to find out. Ask your doctor, do I need to do implantation testing? What do you recommend for me? Have we done all the tests we need to do? Do I have enough embryos for the family size that we want? Those are the things that you can do to prepare, like acupuncture as well. And at the end of the day, you gotta surrender, let it go, sing it like Elsa, and then go right to your transfer and be super excited. Next question, low follicle count and got blasted with max dose for 4 weeks. I've heard you and other docs say high dose can have negative effects on egg quality. Can you speak about this? I would say if you were blasted with hormones for 4 weeks, talk to your doctor about why and see, if there are any other protocols for you. If you have a low egg count, I like to use a hybrid approach. It's kind of like a mini IVF, which people know what that means because a lot of people know what mini IVF means, but I like hybrid because it's a combination of pills and injections, and then basically you're not going to have a blasting of your eggs. Next question, let's see here. High dose gonadotropins and effect on egg quality, someone is asking again. Here we go. Dr. Aimee is incredibly empathetic. Oh, this is sweet. She did an egg retrieval at 5:45 in the morning. I do that. I've done that before. Is just seeing a yolk sac, and thank you for that, that's very sweet. Is just seeing a yolk sac at 5 weeks, 3 days a good sign? Was it too early for a fetal pull? And the answer is yes. A yolk sac inside a gestational sac is all I expect to see at 5 weeks, 3 days, and I'm doing virtual high fives with you if that's what you've seen, so that's pretty awesome. Next question, I'm 38 years old, my AMH is 3.59, FSH is 7, BMI 20, I completed my HSG hysteroscopy and no other issues found so far, no sperm issues either. Which protocol would you suggest for my case for the IVF cycle? I'll tell you what I would do is try and get about 15 mature eggs. Based on your hormone levels, you look like someone who can totally do that. Talk to your doctor about what your antral follicle count is, and that's a really important predictor also of the number of mature eggs that you can get. And I would take CoQ10 if you're not already. Talk to your doctor about whether they would want you to add HGH or Omnitrope to your protocol. For me, anytime I have a patient over 35, I always think that egg quality could be an issue. So I always just add it to the protocol, but you want to talk to your doctor ahead of time. I just don't like to do a cycle and be like, oh yeah, egg quality is an issue. Next time, let's do this, that, or the other. I want to do this, that, or the other this time, not next time. And then be sure to look at sperm too. Remember that S in the embryo diamonds that I talked about at the very beginning. Make sure your partner is also taking sperm supplements so that they can make your eggs look good when it comes to the egg retrieval. Another great question, thoughts on Neupogen for recurrent implantation failure with PGS normal embryos. Recurrent implantation failure is a really, really tough thing. It usually refers to people who've transferred 2 to 3 embryos without any clinical pregnancy, or I should say without having a healthy pregnancy or viable pregnancy. It could be a negative pregnancy test, it could be a biochemical, it could be even a miscarriage. And I'm sorry that you've gone through that and had that diagnosis. I have used Neupogen probably in about, successfully in about 10 patients, but I feel like we have other things that can be more helpful than Neupogen, and certainly I do all those tests. And then if I'm still at a loss, I have added Neupogen and had success with it. And so I would say that it's considered controversial only because there isn't a robust body of scientific literature that supports the use of Neupogen in patients with recurrent implantation failure. But when you're still wanting to transfer and carry yourself, I think Neupogen could be a way to potentially overcome some issues, and it's definitely something that I've tried before, but not without side effects. Neupogen can cause high fevers, severe rash, and it's super, super expensive. Most insurance companies don't use it, but those are my thoughts on Neupogen. Next question. Wishing everybody luck here. If the fertilization rate is 50%, could there be a problem with the lab? And the answer is there could be, but we're also dealing with human biology. There's a reason why you guys aren't getting pregnant, and typically it could be a sign that there's an egg issue, a sperm issue, or both. So when I have a fertilization rate of 50% of mature eggs, I always say to myself, I wonder what I could do differently next time if I need a next time to support egg quality, and that's the list of supplements that I share with my patients. And then same with sperm, is making sure we're not missing any big picture issues with sperm. And then also looking at genetic stuff and asking ourselves the question, have we done enough genetic screening? Chromosome analysis is pretty much the one test that I would do on both, and then sperm DNA fragmentation as well on the partner. Okay, let's just see if there are any other questions. What do you think of Lovenox being used prophylactically in women with no known clotting disorder? So I would say, I don't think that it makes sense. So I would say that if there's a reason to use Lovenox, I do it. Sometimes I do it, you know, if I think there might be some issue that I can't quite like put my finger on, and I know that sounds kind of hocus pocusy, but fertility is a little bit like magic. We kind of make the impossible seem possible. So sometimes there's a little bit of magic involved, and that's kind of where, that's kind of why I'm saying sometimes I use things that you don't have a test for. And so I do sometimes use Lovenox, and I call it empirically meaning without any scientific evidence that the patient needs it, but I don't do it for a long time. I'll typically start it 2 days before transfer until a positive heartbeat ultrasound, and then I have the patient stop it. Another question is, how much time do you have to wait between retrieval and transfer? It really depends. If you're going to do a frozen embryo transfer, remember your embryos can be frozen indefinitely. It's not like the bagels that I have in my freezer that have freezer burn, right? Your embryos are going to be just fine in 6 months, in a year, in 3 years. I mean, I've been in my office now for 13 years, and I have patients who've come back for 4 babies now. Yes, 4 over the last 13 years. And those babies don't have freezer burn. That's funny, you guys. So you can wait as long as you want. You don't have to wait either. You can transfer the next month with your next period, or wait 2 or 3 years if you want. Next question, is there anything can be done with a contracting uterus after transfer? And yes, I use Valium 30 minutes before a transfer, and it usually lasts in your system for about 4 to 6 hours. I have antiphospholipid antibody syndrome, was on baby aspirin, Lovenox, and progesterone during my last pregnancy, and still had a miscarriage. I'm sorry, very, very sorry. Is this normal, and do you have any advice? A steroid. So what I would say is, are your embryos genetically tested or not? If not, consider genetic testing of embryos before you transfer again. The next thing I would ask is, have you done a cavity evaluation? Have you done implantation testing? And what I mean by that is the ERA test and the Receptiva test. So those are the 2 tests that I would have you consider doing. And then depending on your age and how many embryos you have and how hard you had to work, you know, if this is now your 3rd miscarriage, you have to ask yourself the question, does it make sense to consider other options like a gestational carrier or not? It's always good to just check in about that, because the last thing you want to do is run out of your ability to create embryos with your own eggs and then realize you should have had that conversation ahead of time. Okay, can I start taking CoQ10 before my FET in October, or is it too late? It's not too late. CoQ10 is something you can start now. It's not too late before October, and that's in a couple months. Could a good quality embryo fail to implant because the quality becomes damaged, or is it problems with the uterus? Okay, so when a good quality embryo fails to implant, it could be the embryo or the uterus, right? So I wish I could send a little camera in with the embryo to watch and see what happens after it gets transferred. You know, guys, if we could culture embryos days longer, we would really know if the embryos had what it takes, but we can't. You know, we put an embryo in at a certain time, and then we cross our fingers and cross our nose, toes, eyes, ovaries. That's a new thing I'm saying. I'm crossing my ovaries for you. Right? That's funny. Okay. So the answer is, a good quality embryo could stop growing once you transfer it because you thought it was good and you're giving it its the very best chance. A transfer may not work because there could be implantation issues between the uterus and the embryo, and that's very complex. I'm just going to say that in general terms. And then as far as the uterus goes, it could be, you know, anything, but that's the reason why we test what we can, and that's why I typically recommend doing extra testing before transfer. Okay, let's see here. What test should be done on sperm? Anything specific if the initial analysis is normal? Yes. So you can go to ballsmethod.com. That's the perfect way of thinking about it. So look at background genetics, like a sperm DNA fragmentation test. You can do a varicocele check, and that's an ultrasound and an exam on a guy. Check labs like testosterone, thyroid, diabetes check for the guy, cholesterol depending on his body size, and talk about lifestyle and what medications he's on, and then talk about sex. See if there's problems in the bedroom, and then address that too. I think a lot of what goes on, especially now as everyone's stressed out, is there's a lot of sexual dysfunction. Okay, next question. Low morphology and motility, what supplements do you recommend for him? I love Conception XR by Theralogics, and you can use code TUSHY, capital T, capital U, capital S, capital H, capital Y. I always wanted to be a cheerleader, so maybe that's why I made all these mnemonics. You guys, I just figured it out. I'm like a fertility cheerleader. I did try out for POM every single year in high school, and I never made it a single time. Maybe I'm making up for that now. So Conception XR is one. And then the other supplement that I really like is Alpha Sperm. You can use the code, let me think about it, capitals, all caps, Egg Whisperer, and the number 50, and you'll get 50% off. No money comes to me. Here's a great question. Is PGD testing worth it for a woman with a balanced translocation considered to be a common variant? Is it worth the cost? And if it's a common variant, meaning that it's not, if it's an inversion that's typically, that's not related to having offspring with any abnormalities or miscarriages, then I don't think that it makes sense to do PGT SR, which is doing genetic testing for structural rearrangements. Okay, here's another great question. Dr. Aimee, I heard some women had decreased AMH after laparoscopy. Is that common, and why does it happen? And the answer is, first of all, AMH stands for anti-Mullerian hormone, and I'm doing this because it can meander as well. You can also think of it as always mean hormone. And if your doctor during the laparoscopy touched your ovary and removed something from it, then certainly the AMH level could definitely drop. But it shouldn't drop by that much unless a lot of the ovary was removed. So that's an important question to ask. Before you go into laparoscopy, say, are you going to remove a cyst? Is there a chance that my fertility can be affected? Because if the answer is yes, you have a really big cyst and we're going to remove it, and we might remove some eggs with it unknowingly, and not that we meant to do that, then you might want to do your IVF cycle first before you do your laparoscopy. Next question is, when trying to conceive, should we have intercourse when the ovulation test reads peak? Not that I want you to have a sexathon. That's my new favorite word because I think it sounds really fun. Not fun, actually. Have sex not as much as you can. Like, I don't want to hear about that. La, 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 la. But like what I tell people is consider having sex at least a few days leading up to your ovulation, right? Does it have to be every day? Does it have to be every other day? Does it have to be 10 times a day? No. And then have sex at least 1 to 2 days after the positive OPK. And the reason is these OPKs, they suck, right? People think they're a reflection of their fertility, and they're actually quite inaccurate tests. So if you have a peak, believe it or not, you could have ovulated the day before. You could be ovulating 3 days later. So that's why I make the recommendation to have sex 3 days leading up to when you anticipate your peak, and a couple days after, and you'll never miss it. And that sounds like a lot of sex. That's 5 days of sex every other day. And I have people that message me all the time when to have sex. So I'm totally used to talking about this. There should be a song that I can sing that goes along with that. Okay, next question is, what protocol for a 39-year-old with an AMH of 0.5? I had a canceled cycle due to a follicle growing very fast, ended up with only 2 very large follicles in 6 days. Antral follicle count is 9. So my thought is repeat your AMH, check a day 3 FSH level and an estradiol level, and consider a hybrid protocol. So it's that mini IVF protocol that I just suggested in the very beginning of the Ask the Egg Whisperer show. And that's a combination of starting with Femera in the very beginning. And I like to see people, if you're a patient of mine, you know that, frequently and early. So it's not unusual. You start medications, I'm going to see you 3 days later. I know, it's hard to not want to see this face like 10 times in 2 weeks. It's totally not true. People really like, I mean, I'm not going to say they hate coming here that often, but there's a reason why I look early, because I can titrate the dose of medications, I can add the antagonist early so I can maximize my patients' chances for pregnancy during their cycle. Okay, here's another question. Is Cetrotide interchangeable for Ganirelix? The answer is yes. And what about Gonadotropin and Follistim? For me, my answer is yes, but you have to ask your doctor. Some people are very, very picky about one or the other. I'm not that picky. I have endometriosis and I've had a laparoscopy. We've been trying to get pregnant for the last 6 months. I have blocked tubes. What is my next step? I'm 26 years old. I would start taking CoQ10 and N-acetylcysteine to help with endometriosis and inflammation in the body. I would ask your doctor, do I have a hydrosalpinx, yes or no? If you have a hydrosalpinx, before you transfer, remove it. The other thing I would do is ask your doctor, do I have adenomyosis? Has the endometriosis affected my uterine walls? And then consider treatment before transferring if needed. And ask, is my adenomyosis mild, moderate, or severe? Those are the questions that I would ask, and then I would go for it. Freeze embryos, make sure you've frozen enough, and best of luck to you. It sounds like you have all the information you need and you're on the right path. Here's another question. Second round of Clomid starting tomorrow. Hubby is fine. My tubes aren't blocked. Blood work is good. What could be the issue? Well, I don't know how old you are, but think about your age. So when I have things that look awesome, I always think, could it be a fertilization issue? Could be a tube pickup issue, meaning there's just something with the and I won't do like the wave here. Could it be something with the ends of the fallopian tubes not being able to pick up the egg? Could it be related to the sperm? And when I say fertilization, it could be egg quality, like maybe there's something with the shell of the egg, maybe something with the head of the sperm not being able, and I'm sure sperm looks just like that, being able to penetrate the egg. And so I think making sure that you've thought about all these things with your doctor, done all the appropriate tests, consider, like, for example, the DNA fragmentation test, extra genetic screening, make sure you're not missing a polyp. You know, those are the important things, and then see what happens. And then, you know, I always tell people my egg whisperer golden rules. If you're my patient, you're going to hear those things. If you're 32 years old and don't already have one kid, consider egg freezing, embryo freezing, or both. If you're, let's say, close to 37 and you have one kid and you want a second, go right to IVF. And then if you're 37 or above and you want at least 1 or 2 kids, consider IVF from the very beginning. And of course, I'm biased. I'm biased because I don't like tears. I hate people that cry in my office because it makes me cry. And there's only so much Kleenex. I have a box of Kleenex here that I can go through a day. Seriously, I go through probably a box of Kleenex a day. So whatever I can do to prevent the tears and minimize the chance that people will have to see me, the better. So that's why I talk like this. Okay. Here's the next question. Thoughts on Ixi, Pixi, Tessie, and Zyma. What's best for a 43-year-old with fragmented sperm? It depends on what the DNA fragmentation is, body size of the guy, testosterone level, previous IVF experiences, and you know, the blast formation rate. Those kinds of things are really important to me, and I need to know that stuff before I can make that recommendation. And I just did an awesome podcast interview with Dr. Blake Evans, and we're going to talk all about sperm and aspirating it and what's better and why, and his award-winning study findings. And that will be here soon. Here's another question. I'm 32 years old, AMH 1.1, mild male factor infertility. We did an egg retrieval last week, 2 eggs fertilized via ICSI, and we have 2 frozen day 5 embryos, a 5BB and a 5BB waiting for PGS. What are chances they will both be normal? I would say they're pretty good. For a 32-year-old, you probably have a 45% chance that each embryo is normal. So you could have 2 normal embryos in that batch. And with 5 BBs, if you were my patient, I would say at least a 65% chance of implantation. And then remember, embryo diamonds, remember all the letters and get that information up front. And that last D is, will these embryos help you fulfill your dreams for your family? Here's another question. Is it safe to have an embryo transfer at this time because of the COVID situation? And the answer is, if you think it's not safe for you, it is not safe. Everyone is different. Some people can shelter in place at home and work from home during their pregnancy. Other people are frontline workers and they cannot do that, and they have to be out in the workforce taking care of patients, for example, as an ER doctor or ER nurse. And those are the patients that I'm asking not to move forward with the transfer for the time being, and we're monitoring things very closely in my community. But ask your doctor that question, because if you feel like it's not safe for you, then it is not. So, and I've definitely asked patients to wait for a variety of reasons. Next question is, my TSH was 3.0 1 month ago, but after increasing the levothyroxine from 75 to 100, became 0.2 after 1 month. Is TSH of 0.2 too low? What should I do next? Okay, that's a great question. So if you are pregnant or if you're on estrogen, that can really make the TSH fluctuate as well. So being at 0.2 is not that big of a deal, but you can be a little bit more creative with your medications. What you can do is go back to 75 micrograms and perhaps take 100 micrograms 3 days a week. So talk to your doctor about that. Do 100 micrograms on Monday, Wednesday, Friday, and 50 micrograms the rest of the week, or do 100 Friday, Saturday, Sunday, and 50 the rest of the time. Yes, someone is saying guys need to be healthy to have healthy sperm. Amen to that. What's the treatment for sperm DNA fragmentation? So the treatment is weight loss if needed, cut the crap out, no pizza, no beer diet, please. Eat healthy, plant-based, just like, you know, your wife or girlfriend or partner is doing as well. Exercising most days of the week, sleeping well, drinking water, you know, all that kind of stuff. Would doing testy surgery be helpful? And the answer is yes. Also depends on the DNA fragmentation. And then someone's saying, now we can blame everything on COVID-19. Yes, we can. Next question is, do you recommend PGT for sperm DNA fragmentation of 34%? And my answer is yes, I would. And I would also recommend repeating the DNA fragmentation and making sure that you have the green light before moving forward, and make sure that he has seen a male fertility specialist to rule out things like a varicocele, low testosterone, and treating those things if needed. We did a SEMA4 gene analysis, all normal. Awesome. So SEMA4 is the extended carrier screen, and we recommend carrier screening for everybody. That's the Y in the Tushy method. For you guys who haven't seen what that is, go to tushymethod.com and get your genetic screen before you get pregnant or start treatment. Here's the next question. I'm 43 and had 2 IVF cycles. Would you recommend donor eggs? And my question is this. Would you look back and say, I wish I would have tried one more time? If the answer is yes, do another cycle. I tell every woman who's over the age of 40, it could take 4 cycles to even get 1 healthy embryo. Yeah. And sometimes even after 4 or 6 cycles, we still can't do it. And that's just a function of age. It has nothing to do with anything that's in your control at all. If you aren't making mature eggs, if you aren't getting fertilization, if your embryos aren't getting to blastocysts, then at that point, I would say it does make sense to move on to donor egg. But if you're making beautiful blastocysts and they just don't have normal chromosomes, then certainly consider more cycles. Okay, I'm beginning my transfer next month. Is there any supplement I should take and food to eat? Yes. My go-tos are prenatal vitamin D fish oil, okay? If you've had miscarriages, sometimes I even recommend CoQ10. So talk to your doctor about specifically what they would recommend for you, but those are the things that I make sure that my patients are taking. As far as food to eat, foods that you enjoy, but obviously you've heard me say this before, the Mediterranean diet seems to be one of the best diets, and plant-based is what I recommend. I love this question. It's all in caps. Dr. Aimee, can you tell me about the supplements for egg health? I'm taking all of them and only have one egg. Well, I would have you consider taking CoQ10. I would have you consider pterostilbene, acai-berry, resveratrol, something in that family. Then there's another thing called NAD, made by a company called True Niagen, and there's a lot of different forms out there, but that can really, I feel, help with egg quality. I know a lot of doctors also recommend DHEA, but I make that recommendation on an individual basis, not for everybody. And here we go. Sorry, who can take N-acetylcysteine? N-acetylcysteine is a supplement that's been shown to prevent the progression of endometriosis and potentially even treat it. I know, isn't that wild? Yes. It can also be a great supplement for people who have PCOS. Some people say it can even help with egg quality. I recommend it for women who have PCOS and endometriosis. Here's another question. Do supplements affect estradiol level during stimulation? My estradiol only went up to 475 before trigger, retrieved only 2 immature eggs with 8 follicles. I'm sorry, that's a tough one. I mean, if you had 8 follicles and your estradiol level was 475, I would say I would have predicted only 2 mature eggs, and the fact that they were immature, again, totally sucks. That's like the most annoying thing ever, and it's happened to me in my patients before. It's very rare, maybe 1% of cycles that happens to, but my suggestion is consider growing your eggs to 22 to 24 millimeters next time, making sure you're doing a 36-hour trigger. Talk to your doctor about a double dual trigger using not only 10,000 units of HCG, but maybe even 20,000 with low-dose Lupron as well, so that you can talk to the eggs in different ways. And then you can also be sure to use your antagonists like the Ganirelix or Cetrotide the night of the trigger shot and the next day. Let's see here. Can I use numbing cream for my PIO injections? And the answer is yes. What else helps with the pain? I would say numbing cream can help. Icing the area first also helps. Here's another question. I'm doing acupuncture twice a week. My embryo transfer is 2nd week of September. Would you recommend to squeeze in 1 session on the day of the transfer? And the answer is yes. I do recommend pre and post IVF acupuncture to my patients, but I never acupuncture shame anybody. If you hate needles, please don't do it. If going to acupuncture is inconvenient for you or financially not feasible, please don't do it and don't worry about it. I will tell you though that my patients who do it, especially in the beginning part of pregnancy, they have less nausea, they feel better, less joint pain, and they have a much better first trimester. So that's why I really like patients to consider it. Here's another question here. 16 mature eggs, 8 fertilized, 0 blast. They get stuck at morula stage or early blast stage and can't be frozen for transfer or biopsy for testing. Recommendations to improve outcome. That's really hard and I'm sorry. Embryo quality is what we're talking about here. Embryo quality, of course, I have my fertility cheerleading acronym, AGE. It's related to your age, genetics, and environment. So look at all of those things. If age is over a certain age, just realize that that happens and it gets to that point 100% of the time for all of us based on our age. Genetics are genes that we just can't control, and it's just how we were born. So just know that, again, that's not in your control. And then environment is really the only thing that we can control. So your body size, your stress levels, your diet, how much you're exercising, the supplements you're taking, and the protocols that you're using. So talk to your doctor about different creative ways to get your but see what they can suggest to help with embryo quality. And that's looking at both egg quality and sperm quality as well, and taking the supplements, doing extra tests, and do chromosome analysis as well to make sure that you and your partner or sperm source aren't carrying any type of translocation. Next question is for the antagonist IVF cycle. My doctor suggested that I be on birth control pills. In your opinion, how many days are good to be on birth control pills before starting the stimulation injection? Okay, so when it comes to birth control pills, for those of you who are wondering, like, why would anyone recommend birth control pills? They should really be relabeled when it comes to IVF fertility planning pills, FPPs, right? It shouldn't say birth control pills on there. They really just allow your doctor to do your procedure at a time that they're available. So that's one way of thinking about it. The other way of thinking about it is birth control pills, and some people can prevent severe OHSS, which is ovarian hyperstimulation syndrome. So if you have like boatloads of eggs, we use birth control pills to suppress eggs. I personally don't use them as much in my practice because most of my patients are over a certain age and have a lower follicle count than a lot of doctors' practices, because I believe that everyone who needs a chance for, wants a chance for pregnancy should have that chance. And birth control pills can sometimes suppress your egg production. But typically anywhere from like 10 to 14 days probably won't make that much of a difference, but it's so important to talk to your doctor about what they recommend for you. And you can even use 2 days or 5 days or 8 days. It doesn't have to be 10 or 14. Next question, could a short period like 2 to 3 days cause a fertility issue? And the answer is no. A super light period where you're not even using a tampon or a liner, that might be a sign of something like scar tissue in the uterus or lack of ovulation, but otherwise a 2 to 3 day period is not abnormal. I'm 39 with an AMH of 1.4 and a high BMI. Do you suggest moving forward with egg retrieval, only diagnosis as male factor, or get to a lower BMI, then do egg retrieval? Great question. I never body shame anyone, anybody. I love everyone is what I wanted to say. You want a baby, you should have a baby. So depending on your BMI, we just need to get it below 40 to get you to egg retrieval. But what I tell my patients who have a high BMI is this: your IVF stimulation is going to be so much more expensive. The amount of medications that I'll need to talk to your ovaries is going to be a lot higher, which means that you're going to spend more money. And that's really a pain in the butt. And it's kind of going to be a pain in the butt because sometimes we also have to do the shots in the butt. So typically for IVF stimulation, we do the small needles in the skin of your tummy, depending on your body size. If it's over 35, we typically have you do the shots in your buttocks just for best absorption. So just know that. And then you have all the time in the world to prepare for pregnancy, right? So you can freeze the embryos and then get in the best shape of your life. Going through this process is so depressing. So it's really annoying to have someone tell you, you need to lose weight first before I'll take care of you. And the only time we really need to do that is to get us down to a BMI under 40, and then we can move forward. I've had so many beautiful cycles in women who have BMIs 38, 39, 37. And then we freeze the embryos and we take our time, get our body size just a little bit lower before transferring. And we build that team around you. It's not just about like, oh, you need to lose weight. I mean, that's really unfair. There's so many things that you can do as far as ways to support yourself to getting there. And I make sure that my patients have those resources. Next question, is a warm foot bath every night helpful during the IVF process? Of course, that sounds fabulous. It's certainly not going to hurt. Love your humor. I am appreciative that you do. My sister doesn't think I'm that funny, so I'm glad you do. How can I get my embryo to stick during transfer? Well, that's the billion-dollar question. Like, how? I mean, the best thing to do is, transfer a really high-quality embryo that has, normal genetics. It has a really high chance of implanting if that happens, and then do the extra testing that I often mention here, the implantation testing before you transfer, and that can help too. Here's another question. I just got laparoscopic surgery yesterday. When do you think I can start my IVF cycle? Great question. So if you're going to do a frozen embryo transfer, especially if your laparoscopic surgery was for endometriosis, if you were my patient, I would say, what are you doing next week? Because endometriosis can come back and come back so fast. So my strategy is, after a patient has surgery, I get them on the phone and we do a post-surgery consult. We review the findings. I talk to the surgeon and we come up with a plan. I make them a calendar. We talk about what supplements they should be taking to prepare, and we go do it. Here's another question. Do you recommend genetic testing of all embryos for women over 40, including if you only have one embryo? And my answer to that is yes. I know a lot of centers don't do that, but it's so important to talk to your doctor about what their recommendations are, because they truly know what's best in their lab. And so I do genetic testing of embryos, even if there's one. It's so important, because if there's one and it's not normal, I don't want to transfer it and waste a patient's time when she could be doing more cycles. So that's my reasoning behind it. So here's another great question. I suffer from hypothalamic amenorrhea. I'll be 34, and the only thing I've ever tried was Clomid. Should I try IUI or just go into IVF? I'm feeling very anxious about all of this. First of all, with HA, it's really hard to get your ovaries to respond, especially with Clomid. There's only like a 25% ovulation rate, if that. Some people say it's even 5 to 10%. So before going to IVF, you can consider other novel therapies to get your ovaries to wake up. So one of them is naltrexone. Naltrexone has been shown to help. 25 milligrams a day. Talk to your doctor, though, about dosing. If they don't feel comfortable using it, it may not be something that they would order for you. And make sure they have the right diagnosis, that it's not PCOS. Sometimes people mislabel people as lean PCOS, as HA when maybe there's lean PCOS, check your testosterone level if it hasn't been done already. But if you know for sure that your diagnosis is HA, don't give up. There's still a chance that fertility pills will work. You can try Femera, for example, 3 to 4 tablets per day for 5 days. And I've even tried it for 10 nights. I've seen responses in patients after 10 nights of Femera. You don't just have to use 5 nights. And then you just come in for frequent ultrasounds to see if your ovaries are working. And then you don't have to wait. Let's say if you try that Femera and it doesn't work, you don't have to wait for a period or induce a period or anything like that. You can go right into the injectables and go from there. Next question is, what causes someone to only get half the amount of eggs retrieved than follicles? I had 18 follicles measuring between 18 to 22, but only got 8 eggs. So when that happens to me, I say, whoa, I wonder if there's an egg quality issue. And then I say, I am so thankful that we had 18 follicles to start with because I needed 18 follicles to get the 8 eggs out. So it could be simply your biology. The other thing it could be is lack of enough HCG hormone to induce maturation of the eggs. So if that happened to you, you want to talk to your doctor. Should I do a higher dose trigger shot next time? Perhaps with that number of follicles, the doctor was a little bit nervous about giving you HCG and they use Lupron. So maybe next time use HCG if you need to, but that's a great question. It doesn't necessarily mean that something happened or something was bad, but it could mean that there's an egg quality issue, but it could mean that you can learn something from the cycle that you can apply to another one if you need to do another cycle. Let's see here. I think I'm doing a good job, but I feel really bad because I have so many emailed questions and I haven't even gotten to them yet. Next question is, what is a chromosome analysis? Is that semaphore? Is it different? Chromosome analysis is like looking at all the encyclopedia books and making sure they're there A through Z. So we have 23 pairs of chromosomes. 22 are called autosomes. And the 23rd are the sex chromosomes, like the XX or the XY that makes us a boy or a girl, so to speak. And so that's what the chromosome analysis is. The carrier screen tells you how many pages are in the books. It looks at the genes. And so you can actually, I don't know if Semaphore does a chromosome analysis. I think they actually do. You can actually send a tube of blood for the chromosome analysis with the carrier screen at the same time. Next question is this. I just had a natural frozen embryo transfer, non-medicated. I only started progesterone pessaries the 2nd day after transfer. For those of you in the US, we don't have pessaries here. Should I be worried as I heard lots of women started the night before the transfer? If you had a natural frozen embryo transfer, it means your ovaries are doing their job, and that is making progesterone. So I wouldn't worry too much, but I'm a checker. I'm a progesterone checker. I check progesterone. I check it a lot. I don't care that other people are like, you check it too much. I don't care. So typically I'll check it 4 days after transfer and sometimes the day before transfer as well, especially in natural cycles to make sure the progesterone level is high enough for my comfort level. Next question is, what supplements should women over 40 take for good egg quality? What about if you have fibroids? Yeah, I mean, that's a great question. So again, prenatal vitamin, vitamin D, fish oil, CoQ10, and then consider the other 3 things, pterostilbene, NAD, and I can't remember the other one. But if there's a chance that maybe your fibroids are related to endometriosis, like adenomyosis, you can also consider adding NAC. And then depending on body size, if there are any glucose issues or if your BMI is, let's say, over 30, maybe add Ovasitol as well. Someone is complimenting my top. Thank you. Where do I shop? All my clothes are about 10 years old. I just find them in my closet. Any recommendation for the over-the-counter numbing cream? Yeah, I mean, there's over-the-counter stuff that you can buy from Walgreens, but you can also get a prescription from your doctor. I can't remember the name of the medication off the top of my head right now. My doctor saw 2 follicles today after 5 days of menopause. I was told to do the trigger shot tonight for timed intercourse. However, my estrogen lab came back at 78. Should I hold off? So 2 follicles, 5 days of menopause, trigger shot today for timed intercourse. I mean, an estrogen level of 78, I wonder if you were on ganirelix or they put you on Femera as well. I mean, that estrogen level is a little bit low for having 2 follicles. Maybe there's one really big juicy egg, but I would call the doctor. It's hard for me to know. Okay, I have 1 posterior intramural fibroid. It looks like it's 10 millimeters. So that's 1 centimeter. The answer is that will not impact your fertility. What is implantation testing and how is it done? So go to my blog, draimee.org, draimee.org, draimee.org. There's just 2 E's in there. I know I made it sound like there were 10. And then put in what is ERA, and you're going to see this article. and you're going to see my lovely face talking about it. And I talk about the ERA test, what it is. I consider it like the Evite for your embryo transfer party. You want to know what time to show up, and you want to make sure you're showing up at the right time, because you don't want to be that person that shows up at the party too early and that looks really awkward, and then you're like, oh dude, I'm out of here. You don't want to be that person that shows up at the party too late and all the tables and chairs are picked up already. If I'm not making sense, just read the article. It's a good one. Hello, Kelly. I'm 33 years old, tushy checked, sweet and normal. Thank you for the hearts. Underwent first IUI on Monday, but got peak ovulation on Saturday evening at 6. Trigger shot was 10 p.m. IUI on Monday morning. Was IUI done too late? Well, this is why I recommend not saving up sperm. Have sex. So you're not worried about the IUI being too late. We don't want saved up sperm for the IUI. And I don't get it. Like, not all doctors are like me. So talk to your doctor about this first, because obviously I don't want to replace information or advice from your personal fertility physician. But I just don't get why people are told not to have sex before IUI. It makes no sense to me. You guys are trying to get pregnant. We don't want saved up sperm. The more you ejaculate, the higher quality the sperm is. And I know that some people are just too stressed out to have sex on demand, or not on demand, have sex when prescribed, but you know, just have sex as you wish. And then you don't have to worry about was IUI done too late. IUI is not as great as it should be. I wish it gave us a really high chance of pregnancy, but honestly, maybe a 5% increased chance, maybe. Next question is this. I'm 41, I have 2 kids, but I'm going through IVF because my tubes are tied. We only have 1 euploid. What do you think the chances are for a live birth? That's awesome. It just depends on the quality of the embryo. Ask your doctor, what is my implantation rate for the embryo quality that I have? I would say that your chances are at least 65%, at least, if it's a normal embryo, but certainly it might be lower depending on the quality. It could be higher depending on the quality. In addition to prenatals, what other supplements are recommended in the first trimester? I recommend fish oil and vitamin D as well. However, in the first trimester, people are super pukey, and sometimes you want to make sure that you're not throwing up your prenatals. So if you're not throwing up your prenatals, then you can take the other stuff. But if you're throwing up, please skip the other stuff. Great question. Any tips to get FSH down? I wish. FSH to me is just a diagnostic tool that tells us what the heck is going on. Track and trend your levels so you understand what's going on, so you have an idea as to what treatments to consider sooner than later. And remember, you're not a number. A high FSH does not define you. It just describes the story. And if your AMH is high, if your follicle count is high, you probably still have good eggs. So certainly don't let it derail your plans. Don't let it make you super depressed. Don't let it control your thoughts, and just push it out of your mind and be like, great, I'm glad I know. This information is going to help me with what I need to do next. Here's another question. Thoughts on labs showing consistent with PCOS, but testosterone is low. DHEA was also lower than normal. Great. So what you're saying is you have a high AMH level and everything else is normal. You're one of a lot of people that are lucky to have lots of eggs, born with a lot of eggs. So that's all that means. You don't have to have PCOS if you have lots of eggs, and I think that can be confusing to some doctors. And when I say doctors, a lot of patients, OB-GYNs sometimes label their patients as PCOS when their AMH is over 3, when they're just born with lots of eggs. Next question. Baseline, I had 31 follicles. Day 5, I had 8 at 10 millimeters. Any chance I'll be getting more to grow? Are these good numbers? The answer is yes. I mean, having 8 follicles is a really nice number at the age of 31, because you're 31. You have 8 31-year-old eggs that you can potentially have retrieved. That's awesome. It's so unfair to tell someone who has 8 eggs, be like, oh, it really should be 12, or studies show that 15 is the best. I mean, 8's awesome. So you're doing IVF for a reason. Go do it. Make sure you're doing enough. Freeze enough eggs or embryos or both for yourself, for your future, and take CoQ10. Next question. How do you treat endometriosis? My doctor wants to do 3 months of Lupron and I don't want to do it. Okay, there are lots of cool ways of treating endometriosis. 1, you can take 1 month of Depo-Lupron and take Femara daily with it. That's a really novel approach that I've been using a lot. 2, skip the Depo-Lupron and just take Femara every single day. Femara can be used off-label to treat endometriosis. 3, there's another drug that's similar to Depo-Lupron. It's a pill form. It's called Orlissa. Talk to your doctor about that too. The cool thing about that is if you hate life while you're taking it, you can stop it and then life will seem a little bit better. I never use Depo-Lupron on patients who have active depression, anxiety, and I always tell patients, I want you to go online and Google Depo-Lupron first. Read the horror stories and then ask yourself, can I handle it? And if the answer is, I cannot handle it, we're not doing Depo-Lupron. And then talk to your doctor about doing a surgery, a laparoscopy procedure, to see if there's any endometriosis that can be removed surgically. Next question here. I had 70 follicles, retrieved 34, and had 5 normal PGT. That's a big drop in numbers, plus all my embryos are BB for a 30-year-old at PCOS. What can I do for better outcome and quality for the number of follicles and eggs? Okay, well, I'm hoping you don't need to do IVF again. You had 5 normals. Unless you want a soccer team, I think you're done. Start getting pregnant and having babies. I think you're fine. In a case like yours, though, sometimes I prefer lower dose stimulation to get about 15 mature eggs and sometimes even get more normal embryos than getting 70 follicles to grow and retrieving 34 eggs. So I'm not tripping about having 5 embryos that are normal out of that, but I'm also thinking, you know, having 5 normal PGT embryos that are BB is pretty darn good. So I'm not worried at all. Here's another question. Sending love from Australia. Thank you very much. I appreciate that. Can you describe a mini stim? Why are these recommended? So you know that analogy, you've heard it before, less is more. Sometimes less is more, right? Taking less stim can give you more eggs in certain situations. And the thing is this, if you, let's say, have 5 follicles and your doctor blasts you with drugs, sometimes only 1 will grow really fast. So taking a different approach and starting with fertility pills first and then bringing in the shots can sometimes get all 5 to grow. So that's the reasoning behind using it. And sometimes I even use it for patients who have lots of eggs for different reasons. It's another approach sometimes that will help. Sometimes I have patients who have lots of eggs too, and I do a standard stim and they don't stimulate the way I would expect them to. So those are the different reasons why I do that. Okay, so someone is saying, I got my FSH down from 9 down from 33, and I would say it's normal to fluctuate. I wish those things were in our control that we can do that. Okay, guys, it's been almost an hour, and I just only answered your live chatted questions. Instagram is gonna kick me out very soon. So what I'm gonna do is this. Listen. I'm going to end this live chat. This was just all the questions. And then I'm going to start another one so that Instagram doesn't kick me out. And the next live chat is going to be all the emailed questions that you guys sent. Because I literally got 8 pages of emailed questions. And I want to be sure that I answer them because last week's Instagram Live did not get saved and that broke my heart. So this week I have 8 pages and I know a lot of the questions are the same. And I want to make sure that you guys get your questions answered. And now I'm going to answer all your emailed questions. I'm not going to take any live chatted questions during this Ask the Egg Whisperer session, okay? This is just for the emailed questions that you guys sent to me. And if I have time to do the live chatted questions, I'm totally going to answer them. So thank you guys for taking the time to send me your questions. And I love getting fertility questions. It's just me, because there's really nothing else that I'm good at. And there's really nothing else that I should be talking about. So thank you guys. Okay, here we go. I am 34 years old. I have DOR and my AMH is 0.56 and FSH is 6.9. I'm likely to have an endometrioma on my left ovary, 17 millimeters. No male factor issue. I'm currently on day 9 of stimulation for my first PGTA IVF cycle. I only have 3 follicles. They're measuring 11, 16, 19. My doctor is planning to trigger me on day 10 and egg retrieval on day 12. I'm worried I won't get enough eggs in order to make a good quality embryo due to low AMH. What will be your advice on whether to cancel this cycle and what will be the best chance of having a successful IVF? I'm afraid if this cycle failed, I'm still getting very few follicles for my next IVF cycle, leaving me devastated on when I can get pregnant with my condition. Okay, so here is my advice. Repeat your AMH and see what it is. If your AMH is really 0.3, then maybe this is a really good cycle to move forward with. It sounds like endometriosis is the title of your fertility book. So talk to your doctor about strategies to improve endometriosis, what supplements you should take. Obviously, you guys know the supplements that I talk to my patients about, especially when it comes to endometriosis. But the other thing to also do is get into the best shape of your life. That's a secret that no one really talks enough about when it comes to endometriosis. Fat cells secrete estrogen. Estrogen feeds endometriosis, so the leaner and meaner you can get, the better. I mean, I tell my endometriosis patients, go start doing sit-ups and bring on that 6-pack. Okay, maybe I don't say it like that, but you guys know what I mean. As far as being worried, it sounds like there are 3 follicles in 11, 16, and 19. With those size follicles, you're looking at maybe 1 to 2 mature eggs. So consider IUI if possible. Consider doing an insemination is what I mean by that. And see if there are other things that you can do, like HGH priming, a different approach, avoiding birth control pills, to see if you can get more mature eggs. There is cycle to cycle variability between cycles. So start your next cycle if, let's say, your follicle count is over 5, and see if that's going to happen. And if your follicle count is still around 3 to 5, then consider moving forward and don't look back. Endometriosis is not good for our eggs. It can cause someone's eggs to decline in number and quality, so get them while you can, and you're definitely doing the right thing. Okay, here is another question. Hi, Dr. Aimee, love listening to your show. Why, thank you. Especially the asking question part. Here are my questions. How long is the window of implantation? So the answer to that question is about 24 hours. What studies do you rely on to validate the ERA? You know, I don't have the actual study to quote you, but there was a wonderful study published in June of 2020. It was a randomized controlled trial comparing people who did the ERA and people who didn't, and the pregnancy rate was phenomenal in people who did the ERA for their first embryo transfer. I think so many times doctors tell patients, you don't need it, there's no science to support it, and we only do it if you fail 2 embryo transfers. But my patients are so lucky to even get 2 embryos because of their age. So I'm not going to wait for them to fail 2 embryo transfers before I talk about doing the ERA. And certainly a lot of patients don't do it, and they still are super successful. So I hope that answers that question. If I might be post-receptive, do I need to do the ERA again, or is the big, oh yeah. So as far as the ERA test, it's not like a pass-fail. It's not like you're good or you're not good or you'll need a gestational carrier or anything like that. When it comes to the ERA test, it just gives me your number. It's your personalized embryo transfer window, and that's it. You can be post-receptive, you can be pre-receptive, you can be receptive, but basically it's defined by the amount of progesterone that your doctor gave you. And we're trying to find the exact recipe for your body. Remember, we're trying to find your evite, your time to show up to your embryo transfer party. It's yours. And we use general recipes and protocols for everybody, but you guys, we're all different. I mean, like, my nose is huge. Most people don't have as big of a nose as me. I'm trying to make a joke. My sister told me the other day that I'm finally growing into my nose. One day you guys will meet my sister. Here is another question. Let's see here. I have a question about recurrent implantation failure and doing an ERA. Due to 3 failed transfers of good quality embryos, I'm going to do another retrieval. Thinking about doing a fresh transfer and testing any that make it to blast. Would I benefit from ERA before a fresh transfer, or results not apply because the protocol doesn't mimic a fresh, so I can do it after my fresh fails? No PGT done. So for recurrent implantation failure, that's when I totally recommend doing PGT, because that's the most likely reason for recurrent implantation failure. Embryos just aren't normal on the inside. So you guys heard my embryo diamond theory. I won't go through it again, but if you missed part 1 of this Ask the Egg Whisperer, go back and watch it, because the first thing I did was talk about embryo diamonds and all the things you need to know about when it comes to your embryos. And finding out if your embryos are chromosomally normal is important, especially when you have recurrent implantation failure. And then I would do things in a 3-step approach. Step 1, just go back to basics. Figure out your diagnosis. Why are you doing IVF in the first place? And figure out what you can do that's in your control to improve your chances. Step 2, with embryo creation, make sure that you're designing your IVF cycle for the diagnosis that you have. And then prepare for embryo transfer. Consider frozen embryo transfer and do implantation testing. However, if you really feel like you don't want to do genetic testing on your embryos, then maybe consider doing the Receptiva test so you're not missing an implantation failure issue related to inflammation in the lining of your uterus. Then step 3, do your transfer. Don't look back and hope for the best. And know that there's so many different ways of making a chocolate chip cookie, right? So many different ways. And it's not like my way is the right way. And eventually, if you do things enough, hopefully you'll have a success, especially if you're making beautiful blastocysts. Next question. Hi, Dr. Aimee. Love listening to your show. Oh, I just cut and copied that twice. I'm not going to read that one again. Here's another question. A little bit about me. Not about me. About her. I'm 34 years old. My partner is 36. I have endometriosis, first removed 2015 on the left ovary, second back in 2019, and on the left again, and it's still here. And I have hydrosalpinx in both tubes. My TSH is 2.36. We did IVF cycles 2. First cycle, 9 eggs retrieved, 6 fertilized, did genetic testing, 2 healthy embryos. Good job. Second cycle, 6 retrieved, 6 fertilized, 3 did genetic testing, still waiting for results. Here are the questions. Question 1. Hydrosalpinx tube. My doctor suggested blocking them versus removing them. My recommendation is removing them if you can. Why? You don't need them. They can cause pain down the road. They might be a source for cancer, ovarian cancer in the future. We know that ovarian cancer originates in fallopian tubes, so that's why we want to avoid just clipping them. But sometimes you have so much scar tissue that clipping them isn't possible. That removing them isn't possible, and you have to clip them. And so if you just have to clip them, that's okay too. But my general recommendation is just remove them. It really doesn't change your surgery time by that much. Next question is, how does either surgery impact my future egg potential? And the answer is, removing a fallopian tube usually doesn't affect your egg potential too much. There have been studies looking at AMH levels before and after tubal removal, and there have been some fluctuations noted in some studies. But I think for the most part, given the fact that you've already done the work, you've frozen your embryos, you have them, and it sounds like you have lots of them, I wouldn't worry about removing your fallopian tubes and having that affect your future egg potential. I would say, go ahead and remove them. Next question is, endometriosis is around 3 to 4 millimeters. They removed one that was 7 millimeters. Would you recommend removing it before the transfer or keeping it during pregnancy? So I have a way to answer that question, and that's the Receptiva test and looking at your uterus to see if you have adenomyosis, which is thickening of the walls of the uterus. So if I have a sense that patients might have endometriosis without being able to see it with my eyes, like on ultrasound or in the walls of the uterus, sometimes I just go to either doing a repeat laparoscopy, which it sounds like you're going to do already, and removing it all, or if there were no hydrosalpinges, the dilated tubes on either side, consider taking Depo-Lupron 1 to 2 months before your transfer. So not everyone has access to the test that I mentioned, but you can try these different approaches and treatments without doing the test first. Next question is, we want 2 kids. How many healthy embryos would you recommend to have on ice? What supplements would you recommend to improve my potential 3rd IVF cycle? I'm fit, healthy, eating fresh French fruits. I'm going to stop listing off everything that she eats, you guys, because I'm clearly embarrassing myself right now. She actually even listed them all off and then said all that jazz, so I'm going to go with all that jazz. So my thing is this. You're doing a great job. With the number of eggs that you have and the number of embryos that you're getting, I don't know that you really need supplements, but if you're not taking CoQ10 and acetylcysteine, maybe consider HGH if your doctor thinks that that's something that you should be adding. Go ahead and do it. But it sounds like you're doing pretty darn awesome when it comes to embryo creation, so I would keep up the good work. Here is another question. Okay, I'm 35 years old. Things were fart. I won't tell you what time I started my first egg retrieval this morning. Things were fine from the start. I did an egg retrieval PGT testing, and I ended up with 2 euploids and 1 mosaic that had 30% abnormality for chromosome 15 and 70% abnormality for another chromosome. This is the question. She actually shares with me what happens with an embryo transfer where she was extremely bloated. Her bladder was so full. So her question is this: does that feeling of waiting for 6 hours, you guys, she waited 6 hours for her embryo transfer, could that contribute to the negative pregnancy test? And she described that she did a transfer and had a negative pregnancy test, which just sucks. And that makes me really, really sad. Or is the failure purely caused by an embryo not attaching, even though it was normal? And the thing is, it's hard to know. My recommendation is you have to use your voice. You have to speak up for yourself. Because if you're miserable, if you've been waiting 6 hours for an embryo transfer and you're literally in so much pain because of your bladder being full, or you're gassy and bloated or whatever is going on, speak up. And there are things that you can do. You can refreeze an embryo. You can. It's not the end of the world. And very rarely that can happen for a number of different reasons. So if you're at that point where you just had it and you can't move forward with a transfer because you're so stressed out, that's the time to tell your doctor, you guys, this is just not working out for me. Please refreeze my embryo. Or make sure that the circumstances are amazing and perfect before you get that embryo in. So her question is about the mosaics. Is it possible that my mosaic embryos can turn into a healthy pregnancy? And the answer is yes, it's possible. A lot of doctors don't want patients to use mosaics for obvious reasons, because they can result in negative pregnancy tests, abnormal pregnancies, and miscarriages. And certainly no one wants to deal with any of those things. So ideally, we want patients to transfer embryos that are defined and described as normal, but I know from experiences, and I've had several now, that mosaic embryos can certainly turn into beautiful, healthy babies. Here's another question. I had my first embryo transfer. It was a frozen embryo transfer on July 17th. I had a biochemical pregnancy at 5.5 weeks. My HCG now is negative as of August 18th. How likely is it to get 2 biochemicals in a row? We did not genetically screen our embryos. I'm 27 and my doctor said most should be normal. We had 6 frozen out of 55 retrieved. 1 failed, so 5 left. My REI doctor is keeping me on the same protocol, which I'm nervous about. Hoping to transfer 2 embryos in September, so afraid of losing one or both. And how long after a biochemical pregnancy should you expect a period? So typically with a biochemical pregnancy, your period will start once the HCG level drops below 15, usually, maybe even 20, you'll start to see your period. As far as what I would do is, you guys know my strategy, diagnosis before treatment, so take it back a notch and say to yourself, why did I do IVF in the first place? If you were given the diagnosis of unexplained, then certainly see what you can do to find out what the possible explanations are, even though you've already gone through IVF, because it could be that one of the reasons why you guys aren't getting pregnant is one of you might have a balanced translocation, and that's why the embryo turned into a biochemical pregnancy. Maybe there's some endometriosis in your fallopian tube, and the embryo was actually stuck in the tube for just a minute, and that's why you had a biochemical pregnancy. So just take it not that you're screaming at me, but take it down a notch, take it back a notch, and figure out the D of the egg whisperer diet, which is diagnosis, and really sit down and talk through that with your doctor. Someone asked me a question to talk about tonight, and that is, what is the one thing I want everyone to know before they do IVF? And you guys know what that one thing is, and that is, what is my diagnosis? And that is so that you can do everything in your control that you can possibly do to improve the things that are in your control, and then after that, you just let it go. So the other thing that I would say in this situation is to make sure you've done a cavity evaluation. Look at the uterus really well with either an HSG or saline sonogram, and then consider implantation testing before your next transfer. So that would be like the ERA test, for example. So thank you for sending in that question. It breaks my heart when anyone goes through a biochemical pregnancy or a miscarriage. And I think it's so hard when you're young because everyone's like, oh, it should be fine. Oh, everything's going to be great. Oh, you don't have to worry about it. And I actually worry more for my younger patients. I mean, I worry for everybody, obviously. I mean, look at these wrinkles. I worry about everybody. But I tend to, recommend genetic testing for younger patients too, especially when you have this quote unquote unexplained diagnosis, because you know that there's a reason that they're there. Okay, so here is a great question. Let's see here. This is about IVF and OHSS and talking about prolonged coasting and thinking if this could be a good alternative and to someone who has PCOS. And so my suggestion is, if coasting is something that your doctor is talking about, I would suggest even doing like a hybrid protocol that I've talked about before, Femera with low-dose injections, and then seeing you frequently and often. And then there's the strategy of using a double dual trigger shot to make sure you're still getting mature eggs, Lupron trigger only, depending on what your estrogen level is. But coasting doesn't necessarily seem to be a really good strategy to like plan for. Sometimes it's something that's done because you have no other choices or options for a lot of reasons, but we tend not to do any coasting anymore because we have so many other medications and tools that we can use for patients to still achieve an egg retrieval in a very safe way. Here is another question. Hi, Dr. Aimee. I went through my first round of IVF in July and did a fresh transfer that didn't take. I'm sorry about that. As soon as I started progesterone suppositories, 2 tabs 3 times a day, and estradiol 2 times a day, I began experiencing extreme symptoms, including waking up anxious, facial twitching, bloating, stomach pain, nausea for hours in the morning, loss of appetite, uncontrollable crying all day long with very negative thoughts, and lots of hair loss. I've lost 40% of my hair. I'm going to read more, but before I read more, I want you to know that's actually not unusual. I'm going to keep reading. After about 7 days on the medications, I felt in my body that the fresh transfer didn't take, and it was a daily struggle to continue the medications until the beta blood work. I also began spotting a few days ahead of the blood work, which made continuing that much more challenging in an already trying situation. I've shared this information with my family doctor, and he suggested antidepressants. This information was hard to process as I feel stuck in this moment. On one hand, I can't wrap my head around taking meds that make me ill. What would you suggest in this circumstance? Should I inquire about a natural cycle? Should I continue with another medicated cycle with antidepressants, not antidepressants, although that sounds better? Should I ask my RE to change my medication protocol? I'm feeling really stuck. Overall, my diagnosis is unexplained. Our first round of IVF generated 11 eggs, 10 fertilized and turned to blasts. We have 9 embryos left. Okay, let's break it down. First of all, your diagnosis is unexplained. I don't buy it. There is an explanation. Talk to your doctor about what the possible explanations are. If you haven't done genetic testing of the embryos, maybe consider doing that as well before another transfer, because it might help you. I mean, it might help know if your embryo has normal chromosomes or not before you put your body through something like that, which is the 2-week wait to make you feel like you're a crazy person, which you totally aren't. And now I'll get to your medication protocol question. Look, you're taking medications that literally make a lot of people feel like they're losing their mind. And I find it totally insulting for someone to say that you have to take antidepressants because you're taking medications that are making you lose your mind. Everyone metabolizes these medications differently. There are so many different ways of taking them. Believe it or not, actually, you guys probably believe it. I own the website Pharmgina, Pharmgina. I just figured someday, one day, someone's going to want to buy it from me. Probably not. You can take estrogen pills, put them in your vagina. That's why I bought it, as a joke. Literally, you take them, put them in your vagina. When you don't swallow the pill, you have less symptoms. Check your estrogen levels early and see if you should be reducing the dose. Switch to a patch. The patch form sometimes is better tolerated than the pill form for some people. And yes, a natural cycle transfer. If you don't feel crazy when you're ovulating naturally, of course you're not going to feel like you're losing your mind when you're doing a natural cycle transfer. That's only obvious and common sense. So use your voice, advocate for yourself, and don't let anyone tell you that what you're experiencing is not normal and that you need an antidepressant. Certainly antidepressants definitely play a role and have a role in fertility care for patients who need them. But to treat symptoms of hormones, no. Nice try though. Next. I just felt like saying that. That sounded really funny. So I have 8 pages of questions that you guys asked me last week, and I feel so bad that I never got to them, that I'm feeling like I'm slurring my words at this point because it's hot as balls here. Yes, I did just say that. So I'm thinking I'm going to be way better on point if I wait and do these questions maybe another time next week. So I'm not trying to be a fertility expert answerer tease, so to speak, but I certainly want to make sure that I'm doing a really good job answering your questions and giving you guys the information that you so deserve. So I'm just going to see here if there are any live chatted questions. Just want to say I'm learning a lot from you. Thank you. Love you guys. If anyone wants to live chat a question right now, before I sign off, I will take the question. And it looks like there are. I have a massive nose as well. Probably not as big as mine. I think that I win every I actually block out the sun. Sometimes I'm like, where's the sun? And I'm like, oh, it's my nose every time. Oh, here's a live chatted question. I'm 38 years old, AMH 6.58, doing an egg retrieval mid-September and just started birth control. What do you think my chances of having a good egg retrieval? I'm pre-receptive when I did my ERA. I think your chances are really good. If your AMH is 6.58, that means your doctor will probably be able to get at least 15 mature eggs. Each egg for a 38-year-old probably has a 25% chance of being genetically normal. If you make it to the blastocyst stage, and it sounds like you have a really good chance of doing so, I predict you'll have anywhere from 1 to 3 healthy embryos per IVF cycle. So remember my embryo diamonds analogy, learn everything you need to learn about your embryos before you transfer, and then do the work that you need to do to make more if you need to. But it sounds like you're in really great position to get a lot of healthy embryos. Last question, can I take inositol during IVF and pregnancy? And the answer is talk to your doctor about that. I do recommend patients to take it in certain situations because it might prevent gestational diabetes and also might prevent preeclampsia. And it's a more natural way of doing that rather than taking like metformin, but sometimes I also use metformin as well. So talk to your doctor about that recommendation. There are studies of women who have taken inositol in pregnancy and the outcomes are really good. So thank you guys again for showing up again for part 2 of Ask the Egg Whisperer, where I read off the emailed questions for this week. And I certainly will get to the questions from last week because I feel so bad that Instagram kicked me off. And I hope you guys have a great rest of your week. Stay safe, stay strong. I'm not going to say stay positive. I'm all about staying strong these days. Channel your inner super person. So find the superhero that you admire so that when you're feeling like pissed off and really shitty, you're just like, ah, you have that really strong person in your head. And then all those like thoughts that are just like, my FSH is high, this is never going to work. Those thoughts get pushed out of your head. If you want, listen to I have a Spotify playlist that I just added. So tune into that, create your own. It's your own like fight music where you're just like, I'm not letting any of this stuff get in my way. Infertility is not going to get in my way. The pandemic's not going to get in my way. Heck no. And build your team around yourselves. So that's something to really think about this week. Ways to find joy during this pandemic and way to find strength, find connections to other people. All of these things are very important to me. I talk about these things with my patients and I want to be sure that you guys know this stuff too. Okay, have a great night. I'll see you guys later. See you next time. Bye.